So when we say pharmacology, I mean most of you know we're talking about medicines, all right? But pharmacology basically encapsulates what we call pharmacodynamics. It includes pharmacokinetics, and we're going to describe those two terms, okay? So pharmacology is the study of medicines and how the medicine affect an individual, and then how the individual affect the medicine. Because don't think it's just the medicine alone that's gonna produce an effect on the patient. The patient is also gonna break down the medicine, eliminate the medicine, that sort of things. So we're gonna look at that. We're gonna look at the more common medicines that we use in cardiology. So when the patient comes to the echo lab, sometimes they're going to be on what we call ACE inhibitor, angiotensin converting enzyme inhibitors. And some of those are your enalapril, your lisinopril. We used to use captopril, those are some older ones, but currently you will see patients coming in with enalapril and lisinopril. Those are ACE inhibitors, angiotensin converting enzyme inhibitors. Then ARBs, angiotensin 2 receptor antagonists. Um, that is called the ARB, ARB. So angiotensin 2 receptor antagonists. Uh, you will see patient coming to the lab with losartan. Some patients will be on irbesartan. Some patient will be on valsartan. So those are examples of ARBs, angiotensin receptor antagonists. Uh, Beta blockers. You have seen a lot of patients who comes in on beta blockers, the metoprolol, the carvedilol. So those are beta blockers. And calcium channel blockers, those includes your amlodipine. So and Procardia. Your you can also see some patients will come on verapamil, Kalen. Okay. Then digoxin. It's not as popular today as it was before, but you still see patients coming in on digoxin. Nitroglycerin. So, we have different formulation of nitroglycerin. You have sublingual nitroglycerin that you put under your tongue. You have nitropatch, nitropase. You have long-acting nitroglycerin, such as your isosorbide mononitrate, isosorbide dinitrate, and your intravenous nitroglycerin. So, they're very, very common in cardiology. And then antiarrhythmic agents, those are the medicine we use to terminate some arrhythmias, abnormal rhythm. We use them also to modify some abnormal rhythm to prevent those um, abnormal rhythm. And one of the common antiarrhythmics is amiodarone. We use it extensively in patients in atrial fibrillation, and the intravenous form we use in patients with ventricular tachycardia. And then the statin cholesterol medicines, um, very popular as well. Uh, we gonna mention some cancer chemotherapeutic because patients who have some tumor, breast cancer, some other type of tumor, gonna be taking um, adriamycin, um, you know those type of medications. So doxorubicin is one of those medicines. So we again, patients who have certain cancer will be on those medicine. And remember that those type of medication can weaken the heart muscle and give rise to a cardiomyopathy. So if the patient is on those medications, those cancer medicine, we tend to limit the dose, okay? the dose of the medicine. Dobutamine, we use dobutamine, um, well, clinically, patients who are in heart failure with reduced ejection fraction very low, and we diurese them, and we afterload reduce them. We can give them dobutamine. We give them infusion of dobutamine to help strengthen the heart. We also use dobutamine for stress tests, dobutamine stress tests. So, and then atropine, we use that when the patient heart rate is very low. If the patient is bradycardic and symptomatic, we can give them atropine to increase the heart rate. Persantin, we use that for stress tests. Adenosine, we use it therapeutically to terminate some abnormal rhythm, and we also use it to do stress tests as well. So when we say pharmacology, okay, we are talking about the interaction between drugs and a living organism, as mentioned before. So the drug is going to produce certain effect on the individual, the living individual, and then the living individual is going to affect the drug. It's going to break down the drug and stuff like that. So that, in a nutshell, that is pharmacology, the interaction between drugs and a living organism. I will break that down into pharmacodynamics and pharmacokinetics. So when we say pharmacodynamics, it's basically the effect of a drug on the organism, okay? The effect of the drugs on the living organism. That's pharmacodynamics. So how the drug, if say you take um, pain medicine. So the drug is going to reduce the pain. That is the effect of the drug. But when we talk about pharmacokinetics now, it's how the living organism change the drugs, okay, or the effect of the living organism on the drug. So when you take that pain medicine, you have to absorb it, okay? If you don't absorb it into the body, it's not going to work, okay? So you have to absorb it. And then when you absorb it, it has to distribute throughout the body, and hopefully it will get to the site where it needs to hack or work. So absorption, distribution, and metabolism. After the drug has accomplished its task, it can break it down. So you break it down. Sometimes it's broken down into uh, a less active compound, or it's broken down into an inert compound that has no effect whatsoever, and then you eliminate the drug, you excrete it, you remove it from the body. So that is basically how the living organism or the patient uh, affect the drugs. So pharmacodynamics is how the drug affect the uh, the patient, and then pharmacokinetic is how the patient affect the drug, essentially. All right, so this is a very busy slide, but um, I think we will probably get to that at a let's see what we have here. All right. All right. So I'm gonna try. The slide is a bit busy, but I'm gonna break it down so you understand it. And the important thing is to understand the slide. So let's go back. All right. So we talk about angiotensin. We talk about ACE inhibitors, angiotensin converting enzyme inhibitors, and we talk about HARB, angiotensin receptor blocker. Okay, so when we talk about ACE inhibitors, angiotensin converting enzyme inhibitors, and HARB, angiotensin receptor blockers, so this slide will let you fully understand those medicines. Now, most of most people with hypertension have what we call essential hypertension. And essential hypertension is, we don't know what caused it really. Because we are humans and we are upright and all that sort of stuff, we are prone to developing hypertension. That's high blood pressure. Even though we don't know what really caused the high blood pressure itself, there are a few things we know. We know that there's too much angiotensin converting. There's too much angiotensin around. We know that there's too much angiotensin, okay? And angiotensin, what angiotensin does, it interacts with the blood vessels and cause the blood vessels to constrict, okay? Angiotensin interacts with the blood vessels and cause the blood vessels to constrict, and that's one of the most potent reason why we develop hypertension. Okay, so if we can reduce the amount of if we can reduce the amount of angiotensin that has been produced, then we can reduce the blood pressure somewhat. I mean, it stands to reason. Again, it has been shown that most hypertensive individuals have too much angiotensin circulating, and angiotensin, when it interacts with the blood vessel, it causes it to constrict and send the pressure up. So if we can reduce angiotensin, we can reduce blood pressure. Reasonable. So this is the step to produce angiotensin. Angiotensinogen is produced in the liver. So the liver produces this this compound angiotensinogen, okay? Then angiotensinogen is converted to angiotensin 1 by an enzyme called renin. Renin is now produced by the kidneys. So the angiotensinogen produced by the liver is converted to angiotensin 1, okay, by the action of this enzyme and renin. So your angiotensin 1 is now converted to angiotensin 2. And angiotensin 2 is the bad actor. Angiotensin 2 is the bad actor. This is the thing that it constricts the blood vessels, send the pressure up. It causes salt and water retention. So it does a lot of bad stuff, okay? It will send the potassium up as well, okay? So angiotensin 2 is the bad actor. Again, your angiotensinogen, which is produced in the liver, is converted to angiotensin 1 by this enzyme, which is produced in the kidney, renin. Your angiotensin 1 is now converted to angiotensin 2 by ACE, angiotensin converting enzyme. So this angiotensin converting enzyme converts your angiotensin 1 to angiotensin 2. Angiotensin 2 is bad, does all the bad stuff. So if we can inhibit this enzyme, we can reduce the production of angiotensin 2. So we have medicines we call ACE inhibitors, angiotensin converting enzyme inhibitors. So it inhibits this enzyme and as a result, reduce the production of angiotensin 2. So you're going to get less vascular constriction. So it's going to reduce the blood pressure somewhat. Okay, so that makes sense somewhat. Also, again, your angiotensin 2 is the bad actor. For angiotensin 2 to do bad stuff, it has to hack on the blood vessel. It has to hack on the kidney. Okay. You can also block the effect of your angiotensin 2 on the blood vessel. So you can Leave your ACE, let the angiotensin converting enzyme convert your angiotensin 1 to angiotensin 2. But you can block the effect of your angiotensin 2 on the organs, the target organs. And that's how you get your HARB, your angiotensin receptor blocker. So your angiotensin receptor blocker, it sits on the receptors that would normally interact with angiotensin 2 and prevent angiotensin 2 from producing its effect. So we just look at two mechanisms. We look at ACE inhibitors and we look at HARB, angiotensin receptor blockers. Okay, so your angiotensin 2 receptor blocker antagonist, again, example of that is your losartan, your valsartan, okay? It blocked the activation of angiotensin 2 at the receptors, and we just showed you that. We just show you how that works. So it blocked the interaction of angiotensin 2 with the receptors. And as a result of that, it caused vasodilatation, so you can see how good it would be for blood pressure. It reduces vasopressin and it reduces the production of aldosterone as well. Okay, aldosterone is also bad, so it reduces aldosterone. What medical use we have for angiotensin 2? We have a lot of good medical use for it. We use it to treat hypertension. We use it to treat patients with diabetic nephropathy, and we use it to treat patients with heart failure. Heart failure, especially heart failure with reduced ejection fraction. So our HARB, or angiotensin 2 receptor blockers, very important, okay? Because it has some very good use, okay? And again, examples of your angiotensin 2 receptor blockers, your valsartan, your losartan, okay? All right, some of the adverse effects, the bad stuff that your angiotensin 2 or your HARB, it can cause dizziness, headache, hyperkalemia, that is high potassium. So you have to look at the potassium, follow the potassium closely. You can get orthostatic hypotension, that is when the patient stands up, the blood pressure can fall, and the patient can have can pass out, syncopal episode. Of course, we can get a rash, can get stomach problems, can get some muscle aches, insomnia, that's not sleeping, renal impairment, and rarely it can give you angioedema, that is swelling in the throat and the patient can't breathe and swallow. Okay, so these are some of the examples of your HARB, angiotensin receptor blockers, or angiotensin 2 receptor antagonists, your losartan, candesartan, not very common, but we use it, candesartan, valsartan, irbesartan, telmisartan, and these are less common. Okay. Now we come to ACE inhibitors. So we showed you in our schematic how your ACE inhibitor works. So it blocks the conversion of angiotensin 1 to angiotensin 2 because ACE, angiotensin converting enzyme, is necessary to convert angiotensin 1 to angiotensin 2. So your ACE inhibitor blocks that. So it inhibits the conversion of angiotensin 1 to angiotensin 2 by blocking the angiotensin converting enzyme. As a result of that, it causes vasodilatation. Blood vessels are going to dilate. It's going to decrease aldosterone production as well. It's going to increase bradykinin and reduce vasopressin. What we use it to treat? We use it to treat hypertension, diabetic nephropathy, and heart failure. The same thing as heart. So the same condition that we use HARBs for, we're going to use ACE inhibitors for. Okay. What are some of the adverse effects? Okay, and you need to pay special attention to these because some of these adverse effects are very classic. So, and the classic adverse effect is a cough. Okay, a lot of your ACE inhibitor patients will come and tell you that they're having a cough. And if they come and tell you they're having a cough, you have to suspect it's the ACE inhibitor. Okay. Also, commonly, well, not commonly, but you have to suspect patients who you start on a ACE inhibitor, if they come and they can't swallow or they have problem breathing, you have to look for angioedema. Okay. Because this can be life-threatening. So getting a history that they have recently been taking ACE inhibitors, and if they having problems swallowing and breathing and stuff, then it might be angioedema. But other effects are hypotension, hyperkalemia, headache, dizziness, fatigue, and nausea. These are some of the more common ACE inhibitors. The more common one, enalapril, lisinopril, ramipril to some extent, and then you need to know the others. Okay. All right. So beta blockers. So we look at our ACE inhibitors and our ARBs. Those are very common medicines. So you need to know a little bit about them, especially the ACE inhibitor, because you're going to have patients who come and they're going to be coughing up a storm. And if you just take a careful history, you'll find that they're taking an ACE inhibitor. Okay. And then if, patients who start having problem breathing all of a sudden, and they're taking a ACE inhibitor, it might be angioedema. Okay, so beta blockers now. Beta blockers very common. We use it quite a bit. One of our main go-to medication in cardiology. Okay, so the mechanism of action, how it works, it blocks the binding of the catecholamines to beta receptors. Okay, so when we talk about catecholamines, we talk about epinephrine and norepinephrine. So, epinephrine is our fight or flight hormone. If you're in some sort of emergency or whatever, you're gonna produce epinephrine, and it's gonna interact with catecholamine receptors, and your heart rate will go up. You'll get increased blood flow to the muscles, and you're gonna either fight or you're gonna run away, for fight or flight. So that's the beta blockers. That's the catecholamines. That's one of the catecholamines. And then the norepinephrine is another catecholamine, which doesn't really work on the muscles. It works mainly on the blood vessels. Okay, so there are 3 types of beta receptors, but we're just going to look at the beta 1 and the beta 2. So the beta 1 receptor is in the heart and the kidney, but mainly the heart. So if you stimulate the beta 1 receptor, you get increased heart rate and the heart contracts stronger. Whereas your beta 2 receptors are in the lung, gastrointestinal tract, and these different organs. So if you stimulate the beta 2 receptor in the lung, then the lung is gonna, the bronchioles dilate. Okay? So they dilate. Okay. So we can block especially, well, let me just mention the beta 2 is also in the blood vessels. So beta 2 receptors is in the blood vessels in addition to the lungs and stuff. And beta 1 is mainly the heart. So we can block the beta 1 receptor. So we have medication that can specifically block beta 1 receptors. And if we do that, then we're going to decrease the heart rate and we're going to decrease how much the heart is contracting. Okay. And then the beta 2, if we use the fact that the beta 2, when it is stimulated, it causes the blood vessels to constrict. Okay. So if we block the beta 2 beta 2 causes the blood vessels to dilate. Okay, so beta 2 stimulation causes the blood vessels to dilate. So, all right, and beta 3 is in fat. We don't really use that much. So what are some of the medical uses for the beta blockers? We use beta blockers to treat angina with patients with chest pain because of narrowing of the blood vessel in the heart. So we use it to treat angina pectoris. So angina pectoris is chest pain because of the blood vessel around the heart constrict. We use beta blockers to treat atrial fibrillation, slow the heart rate down. Other cardiac arrhythmias, use it for patients with congestive heart failure, essential tremors, glaucoma, hypertension, migraine prophylaxis, mitral valve prolapse, patients who have heart attack, okay, patients with postural orthostatic tachycardic syndrome, patients with anxiety, hyperthyroidism, aortic dissection, hypertrophic cardiomyopathy. So we use beta blockers quite extensively. What are some of the adverse effects of beta blockers? Nausea, diarrhea. Again, remember we said that the beta receptors in the lungs cause the bronchioles to dilate. So if we block those beta receptors in the lungs, then the bronchioles constrict and they can start wheezing. So patients who are prone to asthma can start wheeze when they give them beta blockers. So nausea, diarrhea, bronchospasm, shortness of breath, cold extremity, bradycardia, the heart rate can go very low. You can get not only hypotension, but you can get an abnormal response. You get hypertension. Patient can go into heart failure, can get heart block, fatigue, alopecia, losing hair, ear loss, abnormal vision, hallucination, insomnia, can't sleep, nightmares, and erectile dysfunction, some of the adverse effects. So these are some of the beta blockers, and we say non-selective. That means these can block either beta 1 or beta 2, non-selective. And you must have seen carvedilol. We use that a lot. Okay, depending where you are, it has different name. So it goes by the name of Coreg, Taliton, stuff like that. Labetalol is another non-selective. Okay, Nadolol, Pindolol, Propranolol, okay, Timolol. So these are the non-selective beta blockers. And then these are the beta 1 selective beta blockers that basically work on the heart. Okay, remember beta 1 receptors are in the heart. So these are atenolol, bisoprolol, esmolol, metoprolol. Okay, so these are beta 1 selective, that they're cardia selective. They're going to work on the heart itself. So we're going to stop here.